Welcome to the Caregiving Podcast. I'm Inga.
And I'm Julie.
And long story short, we have Caregiving. We are two momtrepreneurs who have built an in-home care business from the ground up, guided every step of the way by God's care and fueled by agape love. Almost 14 years later, we felt called to create this podcast as a resource for families with caregiving needs. Whether you care for a family member or are looking for advice on professional caregiving, we want this to be a platform to support you.
Each week, we will come to you with encouraging stories of families who have found the right balance for their loved ones, tips for how to care for them and you, and much more. We hope you continue to join us each week as we share in this exciting new journey together.
Hello, Sunshines, and hello, Julie.
Hi, Inga.
Here we are.
Here we are.
How are you?
I had a thought.
Oh, boy.
My hair knows when it's podcast day.
Does it?
Yes, because I'm like, hair, behave. No.
I think it looks great.
It's wild.
It's kind of in that wild, disheveled
going through
look.
A not hold backwards
Yes.
thing. I did it on purpose.
Nice. Good job.
Yeah.
Well, I tried, and I've been very insecure. Like, does it look stupid? Is it too high? Yeah, I don't know. Yours is just cute without trying.
Weird.
So good job, hair.
Yeah, low maintenance, man. That's my middle name.
I've got a lot of gray sprouting through.
Great.
I apparently let my appointment go too long.
Great.
I've got to get with Kevin because he has his regularly scheduled haircut appointments, and we see the same person. So he usually makes my appointments for me.
Well, you better hurry up because the fair's next week, and you're going to be in front of a lot of people.
Yeah, well,
no pressure.
I probably will I'll get some Rust-Oleum.
Up, it's embarrassing.
I'm going to get some Rust-Oleum, as you would say. Just spray it on there. Nobody will know.
Yeah.
Okay. Well, anywho, so we're here.
Yeah.
Last week we talked about disaster preparedness and all the fires that were happening.
Yeah.
Is everything under control that we know of at this point?
I haven't even heard anything new today. I think with the colder weather, and we actually have gotten some rain, that's really helped. Probably not put it out, but at least suppressed the growth is what I'm hoping.
It was crazy because we went to a show in Washington over the weekend, and as we drove through that Nirata area, you could literally just look up on the mountainside and see flames. I mean, just big, huge flames in multiple areas. And there were some houses, some ranches, some farms. Like, I'm just like, how did they not? Those people must have been just dying because you could see where the fire had come so close to their houses.
The worst.
But anyway, I haven't heard about it being catastrophically blowing up again. So hopefully things are kind of under control at this point.
I think that's what I've heard.
Yeah. Good. Good.
Yep,
okay.
Yep.
Well, we have a topic today that we're going to be talking about, and we'll get there and we'll tell you all of the different experiences that we've had with it. But as a preface to that, Julie, have you ever been admitted to the hospital?
Well, knock on wood, no, except to have my babies. And that has been it. I have been with people that have been admitted, and it's not a good time. No, nobody wants to do that on purpose.
Oh, I can't imagine why you would.
Right. What about you?
Well, so now that I'm an employer and understand workman's comp and how it's there to help our people when they get hurt. So we definitely want to have it.
Yeah.
But also if there are claims against workman's comp, then that means more money for the employer.
Yeah.
Well, I have the weirdest workman's comp situation. It's almost unbelievable. When I was quite a bit younger by a lot of years, like over 20. Anyway, I was working at this particular place, and I fell at work. It was during winter time, and it was a job that I had to be inside and outside, and I fell, and quite literally my ovary flipped over on itself inside of my body, and so it cut off all the blood, and the organ was dying. It's weird. But anyway, so long story short, I had an emergency hospital visit and then a surgery. They had to take it out.
Good grief.
Because
How did
I
you
slipped
fall?
and fell.
That must have been epic.
Well,
and it's
I don't even know
that it wasn't on video because I'd probably laugh at you.
I know, back in the days before that was a thing. Yeah. So I can't even tell you. I don't even know.
That's the worst.
Isn't that bad?
It had to be excruciating.
It was weird. And Kevin laughs at me because I was like, no, I'll be fine. I'll be fine. And the pain was probably greater than labor pain, honestly, because literally that organ is just dying inside your body. There was no blood flow to it or anything like that. So that was my first true experience, I think, with hyperventilating, where my whole body was just numb, and I was like, no, I'll be okay. I don't want to go to the hospital. But, I'm like, it'll be fine. Just let me just like, I'll walk it off. No. Anyway. So yeah. So that was my weird hospitalization. And I'm trying to remember how many days I was even there.
Really?
Yeah. A couple days anyway.
Gosh.
Yeah. Anyway, I think that's it though. Other than like, baby and weird things like that. I've had some outpatient type surgery things and at the hospital, but never anything. Well, never any extended stays.
I did not know that weird story of you.
Isn't that crazy? I'm like, oh my gosh, how did I do that? I don't know.
Right. Yeah. Wowzer.
Anyway, so there we go. So not too much hospital experience, but well, let's roll into our verse.
Yes.
And then we'll get to good news stories, and I'm super excited about mine. But the verse today, this is 2 Timothy chapter 1, verse 7, and it says, "For God has not given us a spirit of fear, but of power and of love and of a sound mind." Mm-hmm. Do not be afraid.
Right. And part of our discussion today is actually being empowered enough to speak to somebody that you may feel intimidated by.
Yes.
And so I wanted to just give some power through the word.
Yes, I love that so much.
Because there's a lot of biblical stuff in there about being bold. Mm-hmm. Most of it's being bold in your faith and knowing to share with others. But in this sense, just knowing that you can be bold.
Yes, you can have a voice. You can advocate for yourself.
Yep. You have to advocate. We're going to talk about advocating for yourself a lot.
Yes. Awesome. Well, can you share with us your good news story?
I can. So get this monthly thing that comes in, and I usually just quick go through it before I throw it away, but it's rural Montana. And it comes from the Montana Electric Cooperative Association. Mm-hmm. Yep. And sometimes they have some eye-catching things. And this one is so cute. It's about a 103-year-old gal that they did an interview on her. Aww. And she just doesn't understand why, because she doesn't think she did anything special. Oh. And I don't think I ever get in the shower without thanking God for hot water. So I loved her because she's so grateful.
Gratitude is a thing, man.
We were just talking about that this morning.
Yes, being thankful, being grateful. Even, you had that post on your Facebook of the cow print or like the hoof print literally in the poo. And it looked like a heart. And I was like, that is just finding the good in the shit. Literally.
Yeah, so it's just a delightful story on her. And actually, I'm not going to tell the whole story because at the end, when I do my grandma saying, I'm going to be quoting her.
Oh, I love it.
Yeah.
Yay, that's awesome. And even better that it's from a Montana publication.
Exactly,
so,
right.
Do you know where in Montana she's from?
If I looked it up. So she lives in the Yellowstone Rural Electric Cooperative area.
Oh, wow.
So down like Bozeman-ish.
area?
Yeah.
Right on. Okay. Well, mine, I happen to be a person who has gotten a few tattoos in my life, and they all have meaning to some degree, some more than others. Mm-hmm. And actually, when I went to Tennessee to visit Sammy, I guess it's been over a year now, we didn't know what we were going to do. And so I was just like, oh, well, okay, think of something for us to do. And I get car sick pretty bad. So I had tipped back in my seat. And the next thing you know, she's like pulled into this place. And I'm like, oh, what are we doing? And she's like, we're going to get matching tattoos.
Oh my goodness.
And I was like, oh God, it's too late for me. I didn't participate in the planning. So now I can't complain. So now I just have to be a rock star and do it, which actually I'm really glad that I did. But anyway, so this story, basically it says, when one woman's father was diagnosed with Alzheimer's disease, a disease that gradually leads to memory loss, she decided to get a tattoo. The tattoo, which features 2 waves and the number 52, had a purpose: to help her father always remember her and their memories together. Isabel shared the video of her showing her dad her tattoo on TikTok, where it quickly went viral with over 18 million views. Oh. She says, it's your birth year, 1952, and 2 waves. One is me and one is you, the daughter said. She can be heard telling this to her father in the video. He's not identified, but in the video, she shows him the tattoo on her arm. I had it on my arm because it'll never fade and you'll always remember it, Isabel continues. And every day you see me, it'll always remind you of us and when you were born and the memories you helped make with me.
Oh.
So basically, if you go and see this video, and we'll have it in the show notes, it shows the moment that she showed her dad the tattoo that after he got his Alzheimer's diagnosis. And after hearing his daughter describe the tattoo, her dad reaches over and hugs her, saying amid tears, "I love you so much."
Oh.
Alzheimer's disease, this disease that leads to memory loss and dementia, affects more than 6 million Americans. And that's according to like recent government estimates. It is the 7th leading cause of death in the United States and the most common cause of dementia among older adults. And that's according to the National Institutes of Health. There's currently no cure for Alzheimer's, but there are some medications that can temporarily help delay and manage symptoms, which in addition to memory loss can include everything from sleeplessness, agitation, depression, anxiety, et cetera, et cetera, et cetera. Anyway, so basically one of the most difficult aspects of caring for someone with Alzheimer's can be if they're no longer able to recognize you. Which I just think it's so neat because in this video, she basically explains why the waves, because apparently he had taught her, I think, how to sail. Oh. And she said it's some of the best memories that she has. And it's just very endearing. So go watch it if you can.
Nice.
And yeah, that was her tattoo. So Sammy, my Sammy girl had she finally got her Botox shots for her migraines. And she has a few tattoos. Actually, hers are way more elaborate than mine. But anyway, the neurologist, or I don't know if it was actually the neurologist or whoever was giving the injections, kind of had a theory that that people with tattoos were a little bit of babies with the Botox. Sammy took it like an absolute champ. I mean, in her face, like shots all over in her face and around and on her neck. And the lady that was giving the shots said that most people actually will cry a little bit on the face ones, and she took it like a champ.
She's a tough cookie.
Oh, yeah.
Golly gee willikers.
Yeah. Anyway, okay. So if you guys have verses that you'd like to share with us or good news stories, please email those to thecaregivenpodcast@gmail.com. And again, I know I say it every time, but Julie likes to have stuff to pick and choose from.
So, I like it a lot.
Yeah. Share those with us. And we today are actually going to be talking about hospital discharges, readmissions, the battle that we fight on a almost daily basis with clients that they have an issue, they go into the hospital, they are either not admitted or maybe they're observed for a day, sent home, and then they're just immediately back and it repeats itself. I mean, I can't even tell you. Don't we have some people that 3, 4, 5 times this happens?
It's so hard. This is going to sound like a soapbox of mine because it tends to be. But the thing is I also understand and try to understand the hospital side of it. But when we see, and we're the ones that end up having to literally catch these people and try to make it work at home until it can't because they have to be readmitted, this becomes my soapbox. I know. So frustrated with it. I've seen it, like you said, almost daily. If it's of people that go in, they get checked, they can't find anything, so there's no reason to admit.
Right. And then they get sent home, but their symptoms aren't even really truly being treated. And they certainly haven't found the cause of whatever's going on.
And to be discharged to say, just watch it and see what happens is not acceptable.
I hear you on the phone a lot of times where you just get amped up and you're empowering these people to say, you go back to the hospital and you tell them. And didn't you recently, I'm pretty sure it was you that basically said, I think she has fractures.
Yeah. I did. We had a poor lady. Gosh, she was at home, and she was such a fall risk that the family finally decided she couldn't be home. They thought she could be at least alone at night because she was supposed to be sleeping through the night. Well, she wasn't. Every time she got up to go potty or something, she'd fall. And our caregivers get in there, and they are our eyes and ears.
Sure.
But the things that they tell us, we are always looking for patterns.
Yes.
We're always listening to the things that really aren't even being said. And the caregiver was kind of explaining the situation, and they had sent her to the hospital because they found her on the floor again before we had gotten there for shift. And they sent her immediately home. And I was like, she can't sit. She can't move. She's got to have compression fractures. And so anyway, they went ahead and called 911 again because she simply was so uncomfortable.
Because I think it was like the 3rd or 4th or maybe even 10th time that she'd
so
been there.
Many times that they just sent her home. I said, they've got to do a spinal X-ray, something because there's something causing this.
Yes.
And they were like, oh gosh, she has lumbar compression fractures. And you know what? Compression fractures, there's not a heck of a lot you can do with them.
Right.
But to be aware that you have them.
Right.
right there is a whole different mindset.
Well, yes. What I think your mind is eased a lot once you at least know what it is that's causing your situation. So maybe it's not going to be fixed necessarily, or that you're still going to have some pain or things that go along with it. But at least if you know what you're fighting, then it's not as scary and you can manage it better.
Well, and we as the caregivers can go in there and be appropriate 100%, knowing that there's compression fractures. So how are we going to sit them to ease them? Pillow position, laying down or sitting in their recliner. You know, what are we going to do? But it's only logical. Now we know where the source of the pain is.
Right.
Drives me crazy.
I know. It's wild. It's wild.
Yeah.
So a lot of this material that we're going to be talking about actually came from Verywell Health. And I think the articles started in like 2020, 2021. But anyway, it's not, I can't imagine that anything has necessarily changed for the better.
No.
Anything that we're learning through this is probably still happening, possibly worse. And I think that over time, Julie, would you agree that it has gotten worse?
Oh, yeah. Yeah, and this is going to sound like it's going to sound, but it's our podcast, so I can say what I want. It boils down to the almighty dollar.
Yeah.
And that's a shame.
Yes.
Because never, ever should money come before trying to help somebody. And especially our elderly. My goodness, there is a reason that they are falling constantly. And
let's get to the bottom of it.
So we're going to talk about how to prevent hospital readmissions, and then also, once again, I don't know if I'm going to be popular or not, but we're going to talk a little bit about how to fight a hospital discharge.
Yeah.
It's important to know, like our Bible verse, you have to feel empowered enough to say no. For example, we just this week started with a new client. He's only 56 years old. He's a decorated veteran. He has had 26 surgeries on his leg. They then took from his knee down,
amputated it
finally, after knowing that they couldn't fix it, and then just sent him home. They didn't put him in rehab. They didn't help him with trying to learn how to be in a walker or with crutches, or however he was going to be able to be mobile. And I know that there's amazing prosthetics out there, but you have to heal first, you know, so I know there's a plan, but it just, the wife was like, we just felt like we were just sent home with nothing, no information. We don't know how to do this. And they were, you know, they never said the word scared. But I can guarantee you they were scared out of their mind.
Probably terrified.
Because they were just like, we don't even know anything on how to take care of ourselves. So we went in there as a request from with our veterans contract to do the home care. And so just doing that was standby assist to help him in or out of the shower or with the sponge bath, whatever the case may be. But he's going to end up going in for another surgery because they sent him home too darn early.
I don't even understand.
It ticks me off.
Well, and what's interesting about it is, and I could be speaking out of turn on this deal, but I think there are surveys and they're like, it's tracked. Like it is, hospitals get dings if they get readmissions, right? So Medicare does not want that readmission.
Yeah.
So why don't we slow this process down?
Yeah.
And like you said, though, so much of it comes down to the almighty dollar.
Yeah.
How much is Medicare going to pay for? How much is your insurance going to pay for? At what time, at what point do they say, okay, we're done with this.
Yeah.
You've had all the time you need. You're going home now. And then is Tuna behind me? No. What are you smiling at?
You.
Oh. I didn't know you'd smile at me like that. I thought there was something happening.
Something's got bunny ears behind your head.
Yeah.
No, I'm just thinking about another situation just recently where this daughter called in and she was petrified to take her mother home. And she said, you know, we thought we had 100 days with Medicare. And now they're saying we don't. So they're sending mom home and we just simply aren't prepared. We're not ready. We don't have anything in the home. We don't know how we're going to take care of mom. And I said, why did they say you couldn't have your 100 days with Medicare?
Right.
And there's the magical formula, all of that garbly goop stuff that you do. And it's one of those things where you have to stay like 3 nights. And then Medicare kicks in for that 100 days if it's an appropriate diagnosis.
Right.
Well, so I said, you go back in there and you say, number one, no, we're not taking mom home because, and I said, say the magic word, she'll be back within a day for readmission.
Yeah.
And I said, and then number two, you ask them why. Why is mother not eligible for the 100 days? I said, don't take their word for it. Make them prove it to you.
Right.
And she was like, ha.
I know you get people like,
I'm just like, you've got to be an advocate for yourself because I can't go in there and do it for you. But I got her so pumped up because she was like, yeah, I can do this. But she needed someone to give her permission to be mad about it.
Right.
And say, you know what? Okay. If we need to take her home, you at least got to hold her for another day so we can get a bed or the appropriate whatevers. Right. And explain to me why the 100 days didn't kick in. It makes no sense to me.
Right.
Dang it. Make them explain themselves.
What we're going to find when we get to the hospital discharge is that a lot of it comes down to like the ICD-10 code, their diagnosis code, and then the CPT code, the billing code.
Yeah.
And an average.
Yeah.
What is average?
Yeah.
Right? So we'll get to that when we get to that.
Well, and this one's actually a little personal for me because when grandma fell and she'd been living with mother, she had broke her hip.
Yes.
And now mom lives in a rural town, 11 miles out of that rural town. Yep. And where she's at, it's not readily available for her to have any home health or PT even home OT care like us. Yeah. And mother is a wonderful caregiver, but she also has, tweaked her back before. She can't physically move somebody that's not able to help with that. And so when they said, well, we're going to send Patsy home, and mom called me, goes, yikes. And I said, Mom, just tell them no. Just tell them no.
You can say no.
Just say no. Just say, I cannot take her home. The house isn't set up because there's even stairs to get into mom's house. I said, tell them that the house is not, the layout is not conducive to it. You're in rural Montana.
Like if you get in trouble, you're in trouble, man.
And we're in the response time for an ambulance. And I'll be darned if they didn't keep grandma. There was no room, and that is another big issue. And I get that, no room at the inn, in these nursing homes or any of this, or rehabs, because of staffing or whatever the reason. And I appreciate the struggles that the hospital and them are having, but in reality, mother was going to be in a big trouble. Right. And unsafe for both grandma and for her.
Absolutely.
So what we said is just say no. So mom marched right in there and said, I'm not taking Patsy home. So they literally kept mother, and I know this is expensive, so here we go. Because there was no place to put her, they had to keep her in a hospital bed until the room opened up for her to then be discharged to a lower level of care where she was still going to get that intensive therapy and all that she needed prior to going home. Now, ours was a success story because then when grandma went home, she still was back to her baseline, let's say. Yep. She's able to get up and down, out of the chair. She was able to toilet herself, and she was able to walk with the walker. That's all we could expect from grandma, but she was able to do it. If she would have gone home immediately after that visit, it would have taken her days to recoup, and it just wouldn't have been as successful.
Yeah, it would have taken, if she would have ever gotten truly back to her baseline.
Right.
But I do have to say there are some positive stories as well. Like when my grandma Fisher was at North Valley Hospital, they kept her. Everything was wonderful. It wasn't even a question. Yeah. They just kept her, and she had therapies during the day and like speech therapy, and until she was truly ready to be able to go home, she stayed there. And it wasn't a fight, and it wasn't a worry. Like we were, as the family, we weren't worried that it was too soon for her to come home. So I don't want to totally say hospital screwed up every time, but.
So that's where it becomes gray, because I don't understand where in one case they did a beautiful job with grandma, and that's a blessing. But other stories that we hear were like, it doesn't matter if they were going to be inpatient or out, even just visiting the ER. Right. We had that guy just yesterday that they sent him home because all of everything was normal. Yeah. And so there was no reason to leave him. Well, I can guarantee you within the next couple of days, he'll be back. Yeah. And so that area is like, why are some people being pushed out so darn fast? The continuity, the consistency of the policy doesn't seem to be there. And once again, I could really offend a lot of people because they're very proud of the work they do, and they should be.
Yes.
It's wonderful. But when you're on our end, and we're picking up the pieces and the messes and trying to help this person be good in their home, it's frustrating on this end of it. Yeah. This is where every end needs to talk to each other for the good of the client.
Yeah, for sure.
Yeah.
You know what I was just thinking about? Do you remember when Sammy was having her gallbladder stuff? We took her to the ER, and the doctor basically implied that she was just like drug seeking. It was just pain. Get over yourself.
Oh my gosh.
And I'm like, I know it's her I know beyond a shadow of a doubt because I had just gone through it. It's her gallbladder. And he literally said to me that it's not. And if I'm wrong, I'll eat a bug. Well, guess what? It was a week later, maybe 2 tops. She was in there for surgery for her gallbladder.
Did you make him eat a bug?
No, I want to though.
Oh my goodness. He said he'd eat a bug.
He literally said, if I'm wrong, I'll eat a bug.
What kind of bug?
I don't know.
A
stinky
bug.
one. Yes.
A stink
I
bug.
was just like, but I think at times they get so jaded in the ER that they do think that a lot of people are just, and we've been on the side of like I remember one time years and years and years ago, we got a frantic call from the Agency on Aging for a gentleman in the Whitefish area. I believe he was like a double amputee, needed to go to the, to be seen at the ER. I don't know why in my pea brain, I wasn't like, well, call an ambulance. But Kevin and I went up, we picked him up, we got into the ER, and they were so dismissive of him and just let him sit there for hours. Well, what ended up happening after I got more information was that actually truly was a drug seeking situation. And there was a lot of history, not just at that hospital, but at other ones and all over the place. So I think that situations like that occur enough that they get a little jaded on it and just think that, maybe everybody's here because they just want pain pills or whatever.
I worked at the ER for a handful of years. I worked for the physicians group.
Yes.
But I never knew when I was going to get pulled into the ER to help with a family member making phone calls on a tragic situation or what. And we would see people come in, the same person again and again and again. And one time I actually asked the ambulance people, because we had one gal, gosh, I don't even remember. It was ridiculous. 20 just 911 calls in 6 weeks or even less. And I went up to her and I go, when you get that call and you know that address immediately, do you just get ticked off or what? And actually the guy said, we know her at this point to know that 99% of the time it's just because she has nothing else in her life. But what about that 1% when she really needed us?
Yeah.
And so I was like,
I think that's a great, well, and we have the client story where it was a husband and wife, and the husband passed away and we were caring for the wife. And then, but because of the payer source, it was minimal amounts of time. It's going to click to you who I'm talking about here very shortly. And she just had call after call after call to the fire department, to the ambulance to pick her up because she'd slide out of her chair or whatever. And finally, the apartment complex that she lived in was like, we just can't have it anymore. And she ended up having to go into an assisted living facility because of all those calls. But the great thing is that now it's more appropriate for her.
Oh, right.
And it wasn't a pain-seeking thing at all. I don't know if it was just impulsivity where she's just getting up when she shouldn't or trying to do stuff, ending up on the floor.
Yep.
But she's thriving now.
Gosh, that's, because we used to get calls daily from her.
Yep.
And because she's settled and in the appropriate place.
Yep.
I mean, we do not condone that people don't live at home.
Yes,
right?
we want
because
that.
Because people want to be at home. But there are the occasional situations where it is appropriate that they have more structure because that's just who they are and they just need that.
Yep.
And they do so well.
Yes.
With not having to remember their medications because somebody else does it for them.
Right.
Or dinner, eating properly, all of that. But she's that case.
Yeah. Yep. Well, she was 24/7 with her husband for years and years and years. And so when he passed, it was just way different. And so she's in the great place. And that's kind of weird success story after it, but yeah, it does happen.
Yeah, I think what we could be doing is just talking about all the examples of situations. But really, actually, what we're going to talk about is what is a readmission. Let's look at the definition of that.
Yes. Before we do that, I have to tell, this is staggering to me, and this is from 2021, so you know it's not gotten better. Did you know that as many as 1 in 6 people on Medicare get readmitted to the hospital within 30 days?
That's crazy.
1 in 6. That's not good. All right. What's a readmission?
Okay. Staying overnight in the hospital does not necessarily mean you were admitted to the hospital. Nobody knows that. Right?
Yep.
You've been admitted to the hospital. In your mind, you've been admitted.
You think if you're spending the night, you've been admitted.
So basically, the word admission refers to a hospital stay when your doctor puts an inpatient order on your medical chart. When you're placed under observation instead, you continue to receive care in the hospital, but you have not been admitted. So that's where the Medicare gets you, because you think that if you have a 3-night stay, you can then go into rehab or into the
have that 100
house.
days. But if you're just in there under observation,
it all depends on how you were coded.
Yep.
The second you were admitted under admission or observation.
Right.
The distinction between inpatient and observation orders affects how much you will pay. Generally speaking, and this is all from the Medicare world, okay?
Right.
Part A pays for inpatient care and Part B for observation. Part B also covers physician fees, whether you are an inpatient or placed under observation. Inpatient and observation status also affects how Medicare tracks hospitalizations. Readmission for the purpose of Medicare is a hospital stay that has inpatient orders and happens within 30 days of another hospital admission. Medicare focuses on readmissions that are related to the first admission and are potentially avoidable.
And I think there's a lot of that.
A ton. And the key word here is avoidable.
Right.
Now, if you go in for a different reason,
Right.
Let's say you had a fall, but now you have pneumonia.
Two different,
They're not
completely different
they're
things.
not
They're
related.
not related. Yeah. So inpatient versus observation, you will likely spend less on an inpatient stay than on an observation stay, especially if you're in the hospital for 2 or more days. For an inpatient admission, basically you're going to pay the Part A deductible plus 20% of the physician fees. And this is again Medicare stuff, and don't quote us on it because yours could be different. You might have different supplements and things.
Yeah,
but
every year the money's amounts change.
Yeah, just know that basically inpatient is probably going to be less out of pocket for you versus observation.
Yeah.
So preventable hospital readmissions, when someone returns to the hospital within a short period of time, especially if it is for the same problem, it raises questions. Did they receive quality care while they were in the hospital? Were they discharged from the hospital too early? Did they receive adequate follow-up when they left the hospital? If the answer to any of those questions is no, the readmission may have been preventable. Medicare Payment Advisory Commission estimated in 2007 that 13.3% of hospital readmissions may have been avoidable. Looking closer, a 2009 study found as many as 50% of the people who were admitted did not have a follow-up visit at a doctor's office after their first hospital stay. Improving care coordination after someone leaves the hospital could potentially reduce those admissions. There are times when readmission is unavoidable, no matter how good the care was. For example, someone at the end of life or someone who has an advanced disease may require more frequent care based on the nature of their condition. People with end-stage renal disease have nearly twice the rate of hospital readmissions as those without.
Well, and that last bit that you were just talking about is, then that person's probably needs to be on palliative or hospice care.
Yes.
So they're not being treated correctly in the first place.
Right.
Because if you're on hospice, you do not get readmitted.
Right. You just get those comfort measures at
just make
home
sure that you're comfortable in end of life. Once again, that's a personal decision.
Sure.
But the one thing that I'm thinking about is all of the things that I was ranting about before we started this conversation was the things where readmissions may be avoidable. Those are the ones that we see.
Yes. So many.
Loud and clear.
So many of them.
Yeah.
Yeah.
So... Okay, so they have a hospital readmissions reduction program, and they have forms that you got to fill out. And my understanding is that also hospitals will get dinged if somebody comes in. They really watch those numbers. So know that the doctors are trying to do quality care. And the physicians, the emergency room physicians that I worked with so closely for several years, man, really admired all of them because when you're an ER physician, you're expected to do a lot in a very short time, not even knowing this person and trying to hone in on what you're doing.
And if you've ever watched the TV show House, you know that patients lie. Everybody lies. So how much actual good information are they getting?
Yes, it's true. So that's where they come in with these hospitalist programs. And if they know who their private physician is, they try to pull them in so that they can take better care of that. But their basic thing is fix it and get them out.
Do you remember the time? Sorry, this is bringing up so many memories.
Right?
Do you remember the time that we were caring for the gentleman who was in an assisted living facility and he had wounds and he ended up at the hospital. He was going there for some type of a surgery and a nurse there saw like one of the wounds or something and made this huge deal.
Yes.
And it was like, I think she called APS and it was this huge thing. We go to this meeting at the hospital and we legitimately say, his chart shows. And the response was, well, we don't look at that.
Yeah.
Like, it's everywhere in his chart for the past however many years, but you don't look at that and you just make an APS referral?
Yeah.
What?
Yeah, I think the rest of the story is between transporting him from his house to the appointment. He had wet himself.
Yes.
But our caregiver had taken clothes because she knew the guy. We knew all of these things, but they freaked out, wouldn't listen to us to get the rest of the story. As you're saying, the whole story was in his chart.
Yes.
It was a fiasco.
I remember.
And I remember we were talking about that nurse just decided that this was her mountain to die on and wasn't even giving us a chance to tell her about the mountain.
What's funny about that, as I'm remembering more about the story, is the guardian for him as a personal outside of any of this worked at APS.
Oh,
remember?
Yes, it's all coming back to me.
Yeah, so he was like, what?
Yeah. Yeah, I remember that. So you do have to be very cautious. And once again, have enough backbone to be an advocate because you can get trucked.
Railroaded.
Really fast.
And, I mean, honestly, to that nurse's defense or credit a little bit, like, she's seeing something that she thinks is a problem. I think, the takeaway is if we could have done the situation over, just reaching out to the agency to say, hey, we've got major concerns about this.
Yeah.
Talking to us and finding out a little bit more information versus just like blowing it up.
Ugh, yeah, it was a
because it was a whole thing.
Oh my gosh!
But you know what?
About that.
Speaking
Thanks
of being
for
empowered,
me.
It was empowering to go and sit at the round table at the hospital and be like,
defend
we the little guy, we're not wrong in this situation. You, the big guy, we're very wrong.
Yeah. We were able to defend every decision that was made, why the caregiver did what she did, what we were doing. We were taking him for care, for goodness sakes. Right.
Oh, yeah. Anyway, so basically they have like on the readmissions reduction program, I mean, they have things in place because I think that Medicare sees, again, from a dollar standpoint, that it costs more money when you have all of these readmissions. So there's different, there's pluses and minuses, I think, to everything, but.
And there are medical conditions that they actually watch for.
Yeah.
And once again, that is those billing codes that you're talking about, an ICD-9 code and what's the other one?
CPT codes.
CPT
the
codes.
billing,
See, people like me that don't like it.
That's good though.
Thank you. Like that kind of
so
stuff.
Smart.
Lay persons wouldn't understand what that is, but basically, if you go in for an arm fracture, there's a specific code that when a biller looks at that, they know immediately where it is based on the code. If you go in for pimple on your butt, there's a whole entire different
sorry if that's
ICD-9 code.
Yes.
And anyways, so those are the things that, that's how they run the reports.
Thankfully, all the programs that we work with we have very minimal CPT codes, lots of diagnosis codes, but the actual billing codes are very limited because we don't do Medicare.
Oh my gosh. So, I think one of the worst jobs in the world is a coder at a hospital.
Really?
Because the book's like this big.
I know.
And it gets very specific at times. Like, okay, they got pneumonia, but is it in the left lung, the right lung, bilateral, upper lobe, lower lobe?
Yeah, there's a lot to consider.
Ridiculous.
Yeah.
Yes.
I always laugh at our Medicaid. Man, we're going to get ourselves into a lot of trouble on this.
think so.
We're going to just tick off
We're
every.
just telling you how it is, kids.
I always laugh though with our Medicaid program because we are required to put down a diagnosis code when we send in a referral. However, we are 1,000% non-medical. So I'm like, who are we to like, shouldn't you with the nurse that goes out and assesses give the diagnosis code, not we as the non-medical?
Yes. That and there are times that those codes are quite offensive.
Yes.
Because let me just be honest with you.
Did you have one?
If you go in and you get weighed and you're a certain weight, they will say minimally, moderately, or excessively obese. And there's not a code that says curvy girl.
That is rude.
That
it's an
is
outrage.
An outrage. And so, yeah, you can look at that and go,
Oh, I'm offended.
I'm so offended.
I just identify as curvy.
That's right. That's right. Anyway, so medical conditions to watch for. A heart attack is one of those that they consider to be readmissions. One of the things that they look at, one of the codes.
Right.
Heart failure, pneumonia, chronic obstructive pulmonary disease, which is COPD, total hip replacement, total knee replacement, coronary artery bypass grafting.
Oh, so this is interesting. Not all readmissions are penalized. So these are the ones that do, if I'm understanding this correctly, those are the ones that they can get penalized for. So the compression fractures in the back, there's no penalty for that because it's not one of these. Am I reading it correctly?
That makes a lot of sense.
So they don't care. I mean, I don't want to say they don't care, but it's not as punitive to them if they have those readmissions. Which, and honestly, is it so for a readmission? Do you actually have to be admitted back into the hospital, or so do all those 5 or 6 ER visits that they look you over and say there's still nothing wrong with you? Does that count? Man, we have more work to do, Julie. We need to look into this a little bit more.
Well, the very next bit says, was your stay a readmission? So if you were hospitalized for one of the medical conditions or surgeries above that we just talked about, it is important to ask about your order status. This will determine whether or not your hospital stay counts as a readmission. So see, who knows this stuff?
I know.
I mean, here you are, your knee
we know just
is
enough
throbbing because you had a replacement and it hurts like hell. And you're like, is this a readmission? I mean, really, is that going to be? I mean, I guess some people, if
you'll
they're
know when
really
you get the
freaked
bill.
out about the bill. Yeah.
That's when you'll know.
Yeah.
Honestly.
So this hospital readmissions reduction program has been proven beneficial for at-risk populations. And that's kind of like the poor gal that had 20 readmissions or visits to the ER within 4 to 6 weeks. There was more of a social component to it.
Yes.
And I think that's where they've been working harder on getting more mental health help for those folks. But we also had the guy that was a drug seeker, like you were saying, and we would have him on video where he'd be walking into the ER and then the edge of the pillar before you walked in, he would bounce his shoulder because he could dislocate himself.
Oh no.
So he'd walk in dislocated. But we could watch him do it. And so
I mean, there's such bigger issues happening at that point.
yeah, exactly right. So that has nothing to do with this, but it just shows you sometimes where medical people, well, people in general, but medical people especially, start to get cynical.
Yeah.
Because the first thing they are, and then we have the opioid crisis.
Yes.
And you gave somebody 20, so now they're addicted and it's your fault. Right. I mean, there is liability out there for everything we're talking about.
That's why we can't ever have fun.
Why in the world would anybody become involved in the medical field at this point?
I don't. That and teaching.
Yeah, true that.
Why would you become a teacher? I mean, God bless them all, but that's a tough deal, especially in the world we're in today.
So there's controversy over the hospital readmission reduction program. Mortality rates for heart attacks, heart failure, pneumonia are high. They were high before they started this program, they say, which once again, I'm cynical about the numbers. You can run the numbers however you want. But after the program was implemented, they said that the mortality rates for heart attack improved, but those for heart failure and pneumonia somehow got worse. Concerns have been raised that this had been caused by hospitals possibly gaming the system. Oh, my Lord.
God, wasn't there a scuttle here several years ago about the hospital and gaming the system?
There's
and
always scuttlebutt.
Kickbacks and all kinds of stuff?
Yep. So, once again, advocate.
I don't understand all that
for
stuff.
yourself. But, like you said, regardless, you can run the numbers.
Yeah.
You can run the numbers.
I don't recommend it, man.
Yeah. For example, if a patient needed hospital care, they could be put under observation instead of being admitted as an inpatient. This would prevent the hospitalization from being flagged as a readmission and could decrease the risk for penalties. Unfortunately, that practice would also unfairly shift costs onto the patient. So, one study found 2.1% increase in observation stays after a heart attack, heart failure, or pneumonia, compared to a 1.7% increase for conditions not addressed by this program. So once again, you can skew it how you want it.
It's a bummer.
Yeah.
And you want to believe that it's not happening, at least regularly. I'm sure it is happening to some degree, but
yeah, you don't go into medicine thinking, well, how am I going to screw people today?
Right.
And that sounds terrible. But honestly, when you're trying to make a buck because medical care is ridiculously expensive, you're looking for ways all the time to save a buck here. And once again, those that have private pay or good insurance pay a heck of a lot more than those that don't have it, so that dollar has to work harder.
Oh man, I know.
So to even break even.
Workman's comp is a tough deal too. I mean, we've had situations with employees here who have gone to the doctor and legitimately been asked, like, are you sure you didn't do this at work? Because I think Workman's comp probably pays a little better.
Oh, that was so
or
maddening.
the brace for Kevin had surgery on his knee, and if it was billed to insurance, it was billed at like 500 and something, but if we paid cash for it, it was like 120 or something like that. I mean, it's a racket. And why do we have to do that, right? You overcharge on one to make up for the other, or why can't we just say it costs $125?
Yep. For
everybody.
Yeah.
Yeah. It's a bummer.
Yeah.
I don't understand all of it, but
yeah.
Anyway.
And they do say that this hospital readmission reduction program has reduced readmissions for several conditions. It has even decreased mortality rates for heart attacks. Still, it's not perfect. Some hospitals avoid penalties by putting people under observation when they really need an inpatient stay. Other hospitals have been unfairly penalized for things outside of their control. Ugh.
Yeah. Can you imagine having to be the auditor? Like we currently are in a Medicaid audit situation, and we don't have a lot of Medicaid clients that we take care of, mostly because the administration of it is just crazy. But I cannot imagine that being somebody's just auditing this stuff all the time. My eyes would cross.
They just have to put their heart away.
I'm sure.
And not get emotionally attached to any of it, and just say these
strictly
are just
numbers. Strictly has to be the numbers.
And I'm looking at the numbers, and it will come out as it comes out. But that's
I just realized that Tuna is behind me. She's been behind me in the chair. Yeah, I just touched her.
She knows that we're animated today, so she's there. She's your therapy
I know.
kitty.
She really is. Anytime she thinks I'm getting worked up, she is just right there in my business. But anyway.
Yeah. Well, and so you don't want to think that. The other thing is, when you get your stinking bill,
look at it.
Look at it.
Yes.
We had one of our clients. He was so diligent on every single bill. He would call them and say, I got billed for 2 towels. I only saw 1 towel. Or, he just nailed them on everything.
Yeah.
Most people
don't even look.
Don't even look at it. Assume it's correct.
Yep.
And just
we've had that like personally a couple times, I think, where it's been like, this doesn't seem quite right.
Double billing or any of that.
They look through it.
And like I said, hospitals don't go out there to do.
No, I don't. I think it's
they all go there
enough.
with the right heart.
Yeah.
And then stuff happens.
Yeah.
You know, there's good and bad and ugly on all of them.
Sure.
And so
I'm sure. What do you think somebody doing a podcast about home care would say? God, those home care agencies, man. No.
What a rip.
What a rip. All right. Well, let's talk about hospital discharges.
Yes.
So basically, the discussion is going to be how to fight a hospital discharge. So about the only aspect of leaving a hospital that is consistent among all patients is that we all do it sooner or later, right? Hospital discharge is the process by which you prepare to leave the hospital. In an ideal world, hospital discharge would take place when both you and your healthcare provider, and your healthcare provider think the time is right.
Exactly.
You would be strong enough, healthy enough to handle not only important discharge tasks and details, but also to take care of yourself once you arrive at your destination. However, we don't live in an ideal world. So in order to understand why problems arise with the timing of hospital discharge and what can be done about it, we need to understand how the decision is made about the amount of time that you will be hospitalized.
So, time out. You have a funny, not funny story.
I do.
About when, and this isn't when he was admitted into the hospital, when Kevin had his knee done.
Oh, God.
And he was like, okay, because I think in most same-day surgery scenarios, you have to be able to pee and you have to be able to eat a cracker.
Yeah, there are some things. Eat some crackers, drink something.
Yeah.
Yes. So Kevin had his knee surgery and did not do well with the anesthesia. Like, he got very nauseous and he was just not. So he's back in the recovery room and they're like waking him up basically. And he's still kind of out of it, like cross-eyed and drooling a little bit. No, maybe not that bad. But anyway, they're like, you can stay as long as you need to stay and we'll just be here to take care of you until you feel like you're ready to go, while at the same time putting his shoes on him and essentially being like, now who's coming to pick you up? We need to call to have you ride here. He's like, sorry, Kevin, you were a mess, man. He was so sick. And I mean, they really did just plop him in a wheelchair and put him in the car. And then he had to, where we were living at the time, we were living in the apartment above the motorcycle shop. And so that was a lot of stairs for him to have to get up. And the biggest thing for him was he was just so nauseated. He was in bad shape. But yeah, we laugh about it still because it was just so contradictory. Like, stay as long as you need. What they were saying, but take as much time as you need, while putting his shoes on and basically telling him to get the heck out of the inn because his time was up.
Oh,
it was crazy.
Word. That's an outpatient where the expectation is you're gonna go home.
Yes. Yeah.
Lord.
We did learn from that though, that if he ever has to have a surgery again, you just have to let the anesthesiologist know that you don't do well with it, and then they can give you some medicines for the nausea.
But you don't know that till the
first time.
Yeah.
Yeah.
Good gravy.
Yep. Okay. So why discharge is your payer's decision. Okay. So before you're admitted to the hospital, your entire hospitalization and any predicted tests, procedures, and treatments must be approved for payment by your payer. That might be an insurance company, a public payer like Medicare, TRICARE, VA, state Medicaid. So to determine what they will pay for, payers rely on diagnostics codes called ICD codes, right? So that's what we've been talking about. And then there's a procedure or service code, and those are the CPTs.
Yep.
Those codes describe what's wrong with you and therefore what treatment or tests will need to be performed to help you. Included in those descriptions are the average amount of time you are approved to be in the hospital to complete the tasks that fall under those codes.
Wow.
It's like the Medicaid matrix.
Yeah.
Anyway.
I've got a sore gluteus maximus. I get to stay for 15 minutes.
Yes. Yeah. What average means is based on the insurance company's opinion on what the ideal patient, someone with no additional problems, would need. So it's not based at all on individual patients or their status. So based on the anticipated codes that have been assigned to you, once your time is up, your payer will no longer pay for your stay. And if they won't pay, then unless you can pay cash, the hospital will send you home. Ugh. Therefore, your date and time of discharge are not necessarily based on your physical readiness. They are in a lot of ways based on the coded payments, which may be in direct conflict with your readiness. So you said it in the beginning, it's the almighty dollar.
Yeah. That just makes me want to barf.
Yeah.
It just makes me sick to my stomach for people that are not able to be the average human.
Right. I know. Because we are also individual. And again, you guys, we are taking this information from Verywell Health. So don't kill us.
Yeah, well, everything I've looked up, these were the ones that seem to be more lay person.
Yep.
But
It's
all
all
of the
saying the
ones
same
that
thing.
pop up when you Google this kind of stuff say the same darn thing.
Yep.
And we're not here to start a fight.
No.
We're just here to educate you, to say if you're concerned about monies or
Right.
your insurance is this or that.
Well, and basically, if you are not average, right, maybe you have, I'm just kind of thinking this through right now, but maybe you have a diagnosis code, but then there's a secondary.
Right.
Or maybe there's, more reasons why you are not recovering like an average person would recover. So I think it's that matter of advocating and being like, okay, clearly I'm not responding to this like the normal person would, or average, whatever you want to say. So what more is going on that really qualifies me to continue to be treated here?
Yeah.
And I do think that there are times, that I think hospitals have people that are individually, like their jobs are just to advocate with insurance companies and to send in, additional information and like fight. Oh, I know.
Are you kidding me?
I'm not going to lie to you, Julie. I love our job. I love coming to this building every day. I love what I do. And when I am out in the community or thinking about things, about jobs that other people have, I'm like, I can never not have the job that I have, because I would really dislike every other job that exists. I just want this one.
Oh, that's awesome.
Yeah.
I love that.
Yeah.
But the thing that you said at the end there, therefore your date and time of discharge are not based on physical readiness. That's my soapbox.
Yep.
Right there, because especially with the elderly, there's people that have multiple things going on. So they go in for their knee, but you didn't know it was going to kick up
whatever else is going.
A heart problem because of the medications or the stress or the anxiety.
Right.
And they're a hot mess.
Right.
And they're scared to fall again.
Yep.
So they're told, don't fall on that knee. Don't twist that knee. Don't weight bear. And they're like, well, how am I going to go to the bathroom then? Because I don't have anybody at home except for 2 hours a day that my contract with the VA or Medicaid allows for me. And they're like,
do you remember back in the day?
Sorry for your luck.
Not that many years. It was pre-COVID, really. We would get calls from the hospital that legitimately this person cannot go home without 24/7 care.
Yeah.
Can you help? We don't get those anymore.
Never.
And I don't think it's because they're going somewhere else. I think it's just not happening anymore.
Yeah.
I remember it was probably last summer. We had a patient that was basically in the Lakeside area. Very, very difficult transfer, had been at the hospital. The caregiver was 100% like, she was not comfortable getting her into the vehicle, taking her home. The spouse was out of town. It was a mess. And I was fighting on the phone with the hospital, like, we are not coming. We cannot take this person home. We're not comfortable. She's going to get hurt. The caregiver's going to get hurt. You need to understand, we are not coming to get her. They did not care. They discharged her, and literally she's on the curb. There was a family friend that came and got her and took her home. And I'm like, what more do we have to say? She is not safe to go home. She is not safe to go home.
Right back.
Yes. Yep.
It was within 24 hours.
Oh, yeah.
It was that same darn day, wasn't it?
I think so. And it was like, what are you doing? Yeah. Well, the rules say this is what we have to do. Like, where's the compassion? Where's the humanity? I mean, this person, literally, you're in the wheelchair pushing her out on this. Good luck.
Yeah.
Well, sorry, she's already discharged.
Oh, gosh. Once they're off the curb, they're
not my problem. And it's
so
sad
it's people
because
like us that are left trying to pull it together for these families.
Well, and you have to wonder, like, I cannot imagine that the discharge planners or the social workers or even the staff there, doctors, nurses, aides, whatever, they can't feel good about that.
No, it's tough.
Wild. It's really wild.
It's very tough. But I do resent, and I'm going to just say it.
No, we've already made the whole world mad at this point. So
everybody off, but I resent feeling so responsible for these people that go home when they should not have been discharged.
I know. We take it on, so lose sleep over it.
Our guy that was on the floor yesterday that went to the ER, they sent him home. He ended up again on the floor within 2 hours. Are you kidding me? Are you kidding me?
I know.
Every time my caregiver goes in there, I'm like, well, let me know if he's on the floor. And
I know.
hopefully he's alive and he's not hurt.
I know.
Are you kidding me?
I know.
Kills me. And I am more worried about our caregivers walking into somebody that's dead.
I know.
And then whose fault is it?
I know. And we take on, like you said, it's such a feeling of personal responsibility when you're like, we are not the only ones that are aware of what's going on. Home health is in there. There's family in there. He's been to the hospital how many times? This is a bigger problem.
Yeah.
Like we cannot just keep sending this gentleman home.
Yeah. The other thing you just reminded me what I wanted to say. Now, if you get discharged and you get home health, which Medicare will pay for, that's the nursing and the therapies, OT, PT, and speech. Fantastic. But you have to find out how long is it going to be before they respond and
To
actually
even start.
come and see you to start the services.
Yeah.
Because if it's on a weekend, fat freaking chance.
Yeah.
If it's Friday afternoon, fat
Forget
chance.
it. It's not going to happen.
And a lot of people get discharged at 5 o'clock on Friday
Yes.
because everybody wants to go home.
Yep.
And so what are you going to do that weekend?
I know.
You're just going to hope that he doesn't have to pee for 48 hours before you get some help, or, you know,
I know.
and there are times that I have said, now, do you have home health coming in? And they're like, what's home health?
I know.
They're not
Totally
even
unaware.
educated
They have
on
no
that. And I'm
idea.
like, yeah, he really, really needs help with his medications. He really needs to have some therapy at home because he's not able to go anywhere for that therapy. It's just mind-boggling.
And people don't know.
And they
don't know.
That's why you and I spend so much time yakking at each other
Yes,
about
ranting.
different topics, because we're trying to educate people to understand. Let's say you have X as your diagnosis. Somebody besides yourself needs to educate themselves on even just knowing, as the disease progresses,
Right.
this could happen, or let's anticipate this. Oh, I'm having a heart attack right now.
I know. Well, you are wound up.
I am hot to trot.
I'm surprised Tuna's not in your lap.
Oh, yeah, well, she knows.
Well, she really is standing,
Big
literally
breath,
standing
big
behind us right
breath.
now.
And I didn't realize I was going to get so wound up, but I should have.
Well,
because this is something we deal with daily.
Yeah, it just triggers so many memories of times
does.
that people were
Some of the
just,
stories you've brought up, I'm like, holy hell, that did happen.
yeah, it's wild.
Yeah.
All right, so when patients should stay longer.
Yeah.
Problems will crop up if you aren't average. Maybe your body's having trouble healing from a surgery. It's possible you've gotten a hospital infection or have been a victim of a drug error.
God forbid.
Older people generally take longer to get back on their feet. For these reasons and others, you or your healthcare provider may determine that the payer allotted time won't be enough for you. If there's been an additional problem like an infection or drug error, the hospital may automatically try to extend payment for your stay and you won't ever even hear about it. But it doesn't always happen that way. So there are financial reasons for you to want to stay an extra day or two as well. For example, if you need to be discharged to a skilled nursing center or a rehab, Medicare won't pay for it unless you've stayed at least 3 days.
But as an admit,
Not an observation.
because there are people, I think I've said this, they stayed 3 days, but day 1 or day 1 and 2
We're only observation.
were observation, so that doesn't count.
Yeah, it's so messed up. And I don't understand that. So basically, if they don't immediately admit you, if we're just going to observe for a little bit, and then they decide, you know what, we do need to admit, that doesn't just automatically become an entire admission. That's crazy to me.
Nope, that starts the clock
Yeah, that's wild.
on that second
Yeah, on the 3
admission,
days,
the official
basically.
admission.
Yeah, that's wild.
Yeah.
Basically, you might be caught blind. What's wrong with you based on your diagnostic code may mean that they'll pay for only 2 days, right? But if you're discharged in 2 days, you may be stuck with the cost of the other facility. So, I mean, it's just wild. And it's crazy that you have to quite literally play the game, right?
Yes.
And that's really sad to me.
Yeah. Yeah. Other reasons you may want to stay. It's also possible your reluctance to leave isn't based on your health status at all. Rather, it's a lack of caregiving support you have at home, or fear that something major could happen and go unnoticed without 24/7 monitoring. That's what we deal with right there.
We just have a client that we're going to be helping who is basically, she just needs the support of somebody being there short term every day, just to ease her fear. It's not that she, Yeah.
And mental health is not a diagnosis for this.
Yes. Yes.
They don't care if you have anxiety.
Yeah. Nope, not at all.
Yeah.
But I love that the family is like, this is what she needs to be able to stay home where she wants to be and just feel more comfortable
and
with
have
it.
the blessing of the funds.
To be able to do it.
be able to do
because Medicare certainly isn't going to pay for us to come check on somebody every day.
No, not for socialization whatsoever.
Yeah, no.
Yeah, maybe you're just lonely and you like the attention you get at the hospital. The truth is, in most cases, these are not good enough reasons to stay. And we've had the people tell us we're not a hotel.
Yeah.
And this is no reason for us to extend this stay at all just because of this reason. We've had them say that to us. And I get that.
Yeah, I understand those ones.
But still, they're not going to have anybody else. Some people, their kids, the closest kid is in Texas.
Right. I think in that case, it's a little more work for your discharge planner or your social worker to help get them set up with some type of a resource in the community. Yeah.
Yep.
Instead of just, oh, sorry, can't stay here because you're lonely at home.
Yep.
See you later. Good luck.
Yep. Hospitals can be dangerous places. Only the sickest of patients are found in hospitals. And along with that, they are found the worst of infections are in there.
Yeah.
And you can contract those. So you don't want to do that. Boy, we're really dissing on hospitals right now, and I'm feeling bad about it. But once again, it's better to be aware.
Yes. And again, they're not all bad. Like every experience it's not all bad. We obviously are just sharing with you some of the horror stories that we've had. But like I said, my grandma's situation, her stay was beautifully done. They were so wonderful. I stayed with her and they treated me so well. Like it was a very good experience. So it's not all bad. Please know that we have had good situations, but we are just talking about the ones that are more dangerous, I guess.
Yeah. The most recent encounter I've had at the hospital was unfortunately my brother, and everything was phenomenal. The nurses were great. The 2 doctors that were assigned during that time were unbelievable.
Yes.
They were so empathetic and so incredibly good to my mom. And that meant a lot to me. Then we had a situation after the discharge, I'll word it that way, that was so bizarre, and I won't go into it, but we had to call them on some bullshit.
Yes.
And we wouldn't have even known about it, but we happened to find out about it. It was like, oh, no, you did
what
not.
What are you doing?
And the second we called them on it, they went, yep, and fixed it.
Right.
And I know you're all wondering, but I can't tell you.
Yes.
But anyway, you just have to be diligent.
Yes. So I wonder, honestly though, Julie, if you think about people that go in with family members like you and I, we have a great experience. And is it because we are good advocates? I mean, and maybe we don't even have to get wild in that advocacy really, but there's just, they know that it's not, I don't know how to say what I'm saying without being really rude to hospitals.
Well, honestly,
but basically they know that there are people that are going to be there that are going to stand up and fight, and it's got to be good, versus the person that comes in by themselves, has absolutely no support system and can't speak for themselves or don't know how to.
Yeah.
I don't know. It'd be interesting.
Well, they're not going to fight with somebody that looks like you or me when we're going to say, oh, no, you did not. And because we're going to call them on it because we know better.
Yes.
There's 95% of the rest of them just think, oh, it's the doctor. He knows all.
Right. Well, and then here's the other thing. I think good patients that are nicer to the staff, that are kinder in their interactions, are, probably, it's like that in life, right?
Yes.
You'll
get
if you're
more
nice,
with
you're going to
sugar
get
than some salt.
Yes. And so I know we have several patients or several clients that are just, at the stage that they're in their disease process aren't pleasant. Yeah. And so when you enter into that situation really mad already and unkind and uncooperative, I can imagine that, probably you're not going to you might get treated how you treat.
They cannot wait for you to get discharged because you have been a pain in the butt.
Yes. I was so mad in the Arby's line the other day. Our schedule lately has been just insane because we're doing this and then we're actually AIing a group of sheep. And so it's been wild, and I've been trying to stay at work late because I was gone for a couple days. Anyway, long story short, I end up in the Arby's line wonderful at 10 o'clock at night. And the kid was so sassy and rude to me on the thing. And I just wanted to be sassy back, but I was like, he has all the power right now and I don't want spit in my food. So anyway, we went through our whole interaction and he gave me the food and I just said, hey, are you all right? And he's like, oh yeah, I'm good. And that's my new strategy. Right? When people are really out of line, I just ask them, are you okay? Because
You've been killing it with that.
I know. So I was like, I really just want to spank you right now for being such a smart aleck. But anyway, it just stops them in their tracks. Really.
Words of advice from Inga Jean Lake.
Yes, you don't punch them.
Oh,
you just ask them if everything's
okay.
Words
of wisdom from Julie Brubaker.
Yeah. Anyway, this has gone on far longer than I thought it was going to.
We're almost done, people. We're almost done.
Yeah.
Staying longer, obviously, may cost you more. If you consider filing an appeal, don't forget that staying longer may cost you out of your pocket. Mm-hmm. You may have co-pays, deductibles, and co-insurance you'll owe. Also, that thing is, before you go into the hospital, unless it's non-emergent, make dang sure your insurance knows and gave you the thumbs up, right? And how to appeal a discharge. Basically, there are steps. Talk to your social worker and tell them, I'm going to fight this. I'm not ready to go.
Right.
Yeah.
And keep in mind that basically, I think if you go about it correctly, the hospital might help you with that fight.
Yep.
Right.
Yep.
So
that
just
sugar concept.
Yeah. Advocate for yourself and, explain why you feel like you're not ready to go home.
Yeah.
Be nice about it. Yeah. Even when you want to give out spankings.
And like you said, your doctors or your nurses probably don't argue the fact at all.
Right.
But they just also know that the clock is ticking.
Right. Yeah.
Right.
Yeah.
So I love that there are those that will fight for you as well.
Yeah, absolutely.
You just gotta find them.
Yep. Find them and basically, again, be kind. And I always say it's not always what you say, but it's how you say it. Mm-hmm. Right. So just be careful in the way that you're interacting with your hospital staff and doctors and nurses and all of this. Because I think if you are kind, they will be far more likely to help you.
And the unfortunate thing is, just like with you and me, people don't want to talk to us unless they have to.
I know.
Nobody wants to go to the stinking hospital unless they have to, right?
Right. For the most part.
And so you just have to make the best of whatever terrible situation you're in.
Yeah.
And be ready to know your rights, be able to advocate for yourself and ask the questions. Just because they look busy, which they are,
yes,
they still need to respect you as the patient.
Take your time. When your doctor is there with you, take your time and ask the questions that you want. Yeah. And do advocate for yourself. If you strongly feel like you are being discharged too soon, you need to be able to talk to your nurses and your doctors about that and explain why you think it's too soon and you're not ready to go home.
Yeah. Or call me and I'll get you pumped
absolutely.
up.
Yeah, Julie will get you fired up, and then you'll be ready for a box match.
One daughter last week, she was I'm so glad I called you. I got to get off the phone. I've got to call them right now. She was just ready to box it out.
Oh yeah, yeah. All right, what did you bring? What did our sweet little lady
our sweet little lady, Ruth Iverson, in this article, her advice. Iverson has lived a long, fulfilling, blessed life. So what is her advice for young people to know how to do the same? I think helping others is the greatest thing you can do, she said, and keep your feet grounded. Of course, I believe they should find a church. They should have faith. I don't know what I'd do without God. As far as a career, Iverson said it's important to work where you love what you do.
Yes.
As you have to have passion for what you do, love what you do, find something you can do with passion. When asked for the one key to a long life, Iverson thought for a moment. I would say moderation, she said. So at 103, what goals are left for Iverson? That question had her stumped for a minute. Then she smiled broadly. Just meet more friends.
Oh,
I
want to meet her.
She's adorable.
Oh, moderation. That's great too.
I hate that.
I know. It says the girl who has 2 moonshines a day now. Not the alcoholic kind. Just the caffeine and sugary syrup.
Says the girl that doesn't have the ICD-9 code of curvy girl.
What is moderation?
What is this thing you call moderation?
Yes, but it is great advice if you want to take it.
It's so good. She's not wrong.
Yeah. Well, hey, this has been really actually good. I know.
I got to calm down now.
Here, I'll give you tuna.
Oh, no.
No,
I don't need the
that won't
therapy
help.
cat.
Okay. Anyway, well, if you haven't yet subscribed, please go do that. Anywhere you listen to podcasts, it's the Caregiving Podcast. Yeah. And again, email us if you have grandma sayings or advice like this, anything that you want to share.
Yes.
We love it. So please email it to us, thecaregivingpodcast@gmail.com.
Yes.
And I think that's it, man. This was a good one. Thank you, Julie.
Wowzer. Wowzer.
Yeah.
It was a good talk with you.
Yeah. Peace out, Girl Scouts.
Have a good day.